Welcome student to MBBS Online Lecture 2021. The topic for today's lecture is about bleeding disorder. Since this is the second part of the video, we have previously discussed the bleeding disorder, thrombocytopenia and related platelets disorder. So in this video, we are going to discuss about the coagulation disorders. So let's get started. First one is a disseminated intravascular coagulation, DIC. What is DIC? It's basically systemic activation of a coagulation and results in the formation of a thrombi throughout the microcirculation. As a consequence, platelets and coagulation factors are consumed and secondary fibrinolysis is activated. So what happens? The endothelial wall or the platelets that are circulating within the microvasculature, they come into contact with the tissue factor that activates coagulation pathway. This can be abnormal since this is not needed for that in microvascular injury, since there is no microvascular injury, but there are some factors that activates the coagulation pathway. We will discuss these factors. So due to this, the platelet aggregation occurs, formation of platelet plug occurs, and fibrin deposition occurs that forms blood clot, and we call it thrombi, that is within the microcirculation. So these thrombi are not confined to one place; they are throughout the microvasculature. So what are the consequences of this abnormal activation of coagulation pathway? The platelets and coagulation factors are consumed. And secondly, fibrinolysis is activated. First, what happens? Platelet and coagulation factors are consumed while forming these abnormal thrombi in the microcirculation. And fibrinolysis is also activated after formation of clot. So what it can cause? It can cause tissue infarction and hypoxia. This is the first consequence, while second is a bleeding disorders. So how it can cause tissue infarction and hypoxia? Basically, it can occlude the thrombi that is forming in the microcirculation that can occlude the blood circulation and can cause tissue infarction. While the bleeding disorder we will discuss in later. What is consumptive coagulopathy? This is directly related to bleeding disorder. It is a term that is used to describe it is due to abnormal coagulation, the depletion of elements required for coagulation occur. What happens since this thrombi that is forming in the microcirculation, we are not needing these thrombi to form within the circulation. So we call it abnormal thrombi. So due to these abnormal coagulation, what happens? Platelets and some coagulation factors are consumed. We call it consumptive coagulopathy. This is the second consequence of DIC that can readily really cause bleeding disorders such as easily bruising, less stoppage of blood. Okay, there is a blood vessel. What happens in capillary? There is a widespread formation of a blood clot within the capillary that can occlude the transport of blood and can cause tissue infarction or hypoxia. Due to abnormal clotting, the platelets and coagulation factors are consumed. We call it consumptive coagulopathy. These are the two clinical manifestation of DIC. Let's discuss pathogenesis, how it can cause. It can be caused by abnormal activation of coagulation pathway, intrinsic and extrinsic. We have discussed these two pathways in the hemostasis in well detail. So how these pathways can be activated? DIC is usually triggered by either the release of tissue factor or thromboplastic substance into circulation or widespread endothelial cell damage. So we are, as we have discussed in the coagulation pathway, that the intrinsic and extrinsic pathways are activated by blood trauma and a thromboplastic substance or tissue trauma, respectively. So DIC usually triggered by release of tissue factor or the widespread endothelial cell damage. Widespread endothelial cell damage exposes von Willebrand factors and collagen that can cause the adhesion of the platelets to endothelial and leads to formation of platelet plug and blood clot. What are the thromboplastic substances that can activate extrinsic pathway? These are cancer cells, also cancer cells within the micro within the circulation can cause the activation of coagulation pathways. Endotoxin or exotoxin that are released by macrophages. Severe endothelial injury can initiate DIC. So these are the two causes of DIC. Complications of DIC, clinical features of DIC. DIC is most often associated with sepsis, obstetric complications, malignancy, and major trauma, especially trauma to the brain. Most often found in arterioles and capillaries of kidney, adrenals, brain, and heart. It can cause kidney infarction, adrenal infarction, brain hypoxia, and heart infarction, or we call it myocardial infarction. That can be caused by the occlusion in the arterioles and capillaries of kidney, adrenal glands, and brain and heart. First, there is a widespread fibrin deposition within the microvasculature. The associated obstruction lead to ischemia in the most severely affected or vulnerable organs. So, due to the widespread fibrin deposition within the microcirculation, there is a tissue ischemia that are to the organ that are more severely affected and vulnerable. That are kidneys, adrenals, brain, and heart. Hemolysis occurs as a red blood cell are traumatized while passing through the vessel, narrowed by fibrin thrombi. Hemolysis also occurs that we call it microangiopathic hemolytic anemia. We have also seen this type of hemolytic anemia in HUS, hemolytic uremic syndrome, and TTP, thrombotic thrombocytopenic purpura. So while red blood cells are passing through these these capillary that are narrowed by fibrin thrombi, they are traumatized. So we call it microangiopathic hemolytic anemia. Second, bleeding diaphysis. What is this? This is result from depletion of platelets and clotting factors, and the secondary release of plasminogen activator. So bleeding tendency is also increased due to the due to many of the coagulation factors such as platelets are depleted due to abnormal formation of clot such as coagulative consumptive coagulopathy. Secondary release of plasminogen activators. So plasminogen activator activates plasmin that cleaves fibrin, but plasmin not only cleaves fibrin, it also digests or it also removes factor 5 and factor 8, further reducing their concentration. So activation of plasmin means fibrinolysis also can cause the deficiency of factor 5 and factor 8, since plasmin not only cleaves fibrin but it also removes factor 5 and factor 8. So bleeding tendency increases. These are the two complications and two main reasons for the tissue infarction, microangiopathic hemolytic anemia, and the bleeding diaphysis. Okay. DIC is well described in this picture, flowchart diagram. There is a massive tissue destruction. There is a sepsis or endothelial injury that causes release of tissue factor. Due to release of tissue factor, it can cause widespread microvascular thrombosis, formation of widespread coagulation within the microvascular. So after the formation of clot, it needs to be dissolved by activation of plasmin. Plasmin plasmin do fibrinolysis, and fibrin is split to products. So also plasmin proteolyze the factors, clotting factor, data factor 5 and factor 8, further leading to bleeding. Widespread microvascular thrombus can also can cause vascular occlusion, as we have discussed, that leads to microangiopathic hemolytic anemia and ischemic tissue damage. There is a there is another cause of there is another result of widespread microvascular thrombosis, that is consumption of clotting factor and platelets, consumptive coagulopathy, that leads to bleeding. So this is a complication related to DIC. What are the clinical features? The manifestations may be minimal, or there may be shock with acute renal failure, as we have discussed. The formation of thrombus is mostly in kidneys, adrenals, heart, and brain. So it can cause acute renal failure, dyspnea, cyanosis, convulsion, and coma. Prolonged and copious postmortem bleeding, or by presence of petechiae and ecchymosis on the skin. So prolonged bleeding time and presence of petechiae, these are the petechiae. These are the micro hemorrhages that occur. So there is ecchymosis. These are the large hemorrhages that occurs within the skin, that can be seen in such as in this picture. So what are the laboratory evaluations? There is thrombocytopenia due to consumptive coagulopathy, prolongation of prothrombin time, and partial thromboplastin time due to depletion of platelets and clotting factors and fibrinogen. Acute DIC can be life-threatening and must be treated aggressively with anticoagulants such as heparin. Heparin, we know that this is anticoagulant. It works with antithrombin 3 to remove thrombin from the blood and acts as an anticoagulant. Or can be treated with coagulants contained in fresh frozen plasma. Now we have completed DIC. Now we will move to the coagulation disorders. We will discuss hemophilia A, hemophilia B, von Willebrand disease. Basically, these three types of coagulation disorder are congenital and hereditary disease. Coagulation disorder results from either congenital or acquired deficiencies of clotting factors. Coagulation disorder can be acquired or congenital. Acquired deficiency are most common and often involve severe factors simultaneously. We will discuss acquired disorder include vitamin K deficiencies. In vitamin K is required for the coagulation activation of clotting factors 2, 7, 9, and 10. Its deficiency can cause severe coagulation defects. Hepatic parenchymal disease are common causes of complex hemorrhagic diathesis. Hepatic means liver. The disease related to the liver, since liver is a main organ which is involved in producing many coagulation factors and also in removing many coagulation factors from the circulation. So liver disease can also cause coagulation disorders. DIC also may lead to multiple concomitant factor deficiency. As we have previously discussed, DIC can also cause depletion of platelets and coagulation factors that lead to coagulation disorders. Hereditary disorders are, as we have discussed, hemophilia A and B and von Willebrand disease. What is von Willebrand factor complex? Basically, hemophilia A and von Willebrand disease are caused by qualitative and quantitative defects involving the factor 8 and von Willebrand factor complex. Circulating factor 8 binds non-covalently to von Willebrand factor. So in circulation, factor 8 always bind covalently to von Willebrand factor. Endothelial cells are the major source of plasma VWF, where most factor 8 is synthesized in the liver. In addition to its role in platelet aggregation, since we know that von Willebrand factor has its role in platelet adhesion, but VWF can also stabilize factor 8. Thus, VWF deficiency leads to a secondary deficiency of factor 8. Okay. Now, von Willebrand disease. Von Willebrand disease is a transmitted as an autosomal dominant disorder. It's a genetic disorder that is autosomal dominant. It usually presents as an spontaneous bleeding from mucous membrane, excessive bleeding from wounds, and menorrhagia. Since von Willebrand disease is a congenital disease that leads to the deficiency of a von Willebrand factor that are present on the endothelium wall. When these factors are absent, so it leads to qualitative deficiency of platelet disorder. Platelet would not bind to platelet would not adhere to the endothelial wall, and there will be no formation of platelet plug and no formation of blood clot. So there is spontaneous bleeding from the mucous membranes, excessive bleeding from the wounds, and menorrhagia. People with von Willebrand disease have compound effects in platelet function and coagulation, as I have discussed. The classic and the most common variants of von Willebrand disease is type 1, that is an autosomal dominant disorder in which quantity of circulating VWF is reduced. Basically, there are two types of von Willebrand disease. Type 1, that is the reduced concentration of VWF in circulation, that is an autosomal dominant disorder. While type 2 is subdivided into two types, that is type 2 also leads to several subtypes characterized by selective loss of high molecular weight multimers of VWF. Because these large multimers are the most active form, there is a functional deficiency of VWF. In type 1, there is a deficiency of VWF, while in type 2, there is a functional deficiency of VWF. Means we can say qualitative defect. In type 2A, that is a subtype of type 2, the high molecular weight multimers are not synthesized, leading to true deficiency. In type 2A, high molecular weight multimers of VWF are not synthesized since there is a deficiency of VWF, while in type 2B, there is an abnormal hyperfunctional. What is hyperfunctional? High molecular weight multimers are synthesized that are rapidly removed from the circulation. These high molecular weight multimers cause spontaneous platelet aggregation, a situation reminiscent of the very high molecular weight multimer aggregate seen in TTP, thrombotic thrombocytopenic purpura. So in type 2B, there is an abnormal formation of VWF that is hyperfunctional, means it can lead aggressive platelet aggregation. This can cause a situation as seen in the thrombotic thrombocytopenia, that is abnormal aggregation of platelets, and this is very aggressive. Mild chronic thrombocytopenia, presumably due to platelet consumption. These are the clinical features. Thrombocytopenia is seen in VWF. Now hemophilia A. There are two types of hemophilia, hemophilia A and B. We will discuss hemophilia A. What is hemophilia A? Is the most common hereditary cause of serious bleeding. It is an X-linked recessive disorder caused by reduced factor 8 activity. Basically, it is an X-linked recessive disorder, mean it is present on the X chromosome, sex chromosome, not presenting on the Y chromosome. So due to this, many of the males are affected by hemophilia A. What happens in hemophilia A? There is a deficiency of factor 8. The varying degrees of factor 8 deficiencies are explained by the existence of many different causative mutations. Basically, there is a mutation in the gene that can be translocation of translocation of gene, substitution, deletion, or many of them genetic mutations can caused by mutations. In symptomatic cases, there is a tendency toward easy bruising and massive hemorrhage after trauma or operative procedures. In addition, spontaneous hemorrhages frequently are encountered in tissues that are normally are subject to mechanical stress, particularly the joints where recurrent bleeds, hemoarthrosis lead to progressive deformities that can be crippling. Petechiae are characteristically absent. Clinical features for hemophilia A include hemorrhages that are spontaneous when there is a trauma or operative procedure. Spontaneous hemorrhages are often seen in the tissues that are more subject to mechanical stress, particularly these are joints. Such as in children's, the joints are most with a hemophilia A, the joints are the most tissues that are subject to mechanical stress. And there we can see the hemorrhages, and it can easily hemophilia A can easily be diagnosed by observing these clinical features. So basically, the deficiency of factor 8 causes the coagulation pathway to stop. So no coagulation pathway starts in response to the vascular injury or any tissue injury. So bleeding is the most common. Bleeding time increases. Partial partial thromboplastin time also increases, PTT. So these are the laboratory diagnoses that can be used to diagnose hemophilia A. In addition to this, family history is also important for diagnosis of hemophilia A, etc. Treatment, how it can be treated? It is treated by infusion of basically infusion of factor 8 by IV. So this is how the hemophilia is transmitted genetically. Hemophilia B. What is hemophilia B? It is a deficiency of factor 9, that is a Christmas factor. It is also an X-linked disorder that is indistinguishable clinically from hemophilia A, but it is less common. In this, the PTT, partial thromboplastin time, is prolonged. The diagnosis is made using specific assays of factor 9. It is treated by infusion of recombinant factor 9. There you can see hemophilia A and B. There are basically hemorrhages within the skin where the skin is subject to mechanical stress, just like this. So think for now, this is the end of the lecture. By the way, if you are enjoying this video, a sub to the channel would be amazing. We would see you in next video. Thank you.